Good afternoon, everyone, and welcome to the latest Injury Rehab Network. We're delighted to have Dr. David White with us today to discuss exercise-induced leg pain. I know from the chat that we've just had it's going to be a really interesting session, and I hope you all enjoy it. Before we do get underway, I'm just going to go through some quick housekeeping. If you could please introduce yourself in the chat. It's always brilliant to see the range of professionals and the range of countries that we have represented at these sessions. So please do let us know where you're joining from. As always, we'll be sending out a certificate of attendance to all of you that are joining us live in this session today. You can use that for your CPD records. The session's going to be around 40 to 45 minutes today. That'll be followed by a short Q&A. So if you could have your questions ready to put in the Q&A box and review what's already been posted, that would be great. If you could just refrain from putting your questions in the chat, it will mean that they don't get missed because we'll only take the ones from the Q&A. I'm going to hand you over to Andrew and then we'll get the session underway.
Thanks, Ollie. Just say thanks to Ollie and everyone from Basrat who's supported the events this year. This is our last one of 2025, and thanks, as always, to everyone who joins the events and contributes to them, but especially to the expert guest speakers like David, who kindly sort of share their expertise and knowledge. So really appreciate David giving up his time today. It's a very busy time, I know, and thanks everyone for joining as always. So I'm Andrew. Apologies if you've heard this many times before. I lead on our work in sport at Steroplast Healthcare. We're a medical supplier based in Manchester. We've been working with Basrat on these events now, I think since 2019. So I think we've done 60 plus of these events, and it's really brilliant to see all the fantastic expert guest speakers, but also how much engagement we're continuing to get in these events. So thanks very much. I hope you enjoy the presentation from David today. We've already got a bit of a schedule for the events in next year sorted, and the presentation from David is linked to the work that he does at the Orth Team Centre. So Dr. John Rogers also did a presentation for us that you hopefully saw earlier in the year, and David's colleague, Dr. Rebecca Robinson, is our next guest speaker in January, and Rebecca's going to be talking about exercise and cancer. So that's a topic that we haven't covered before, and I'm sure will be of interest. But I hope you enjoy David's presentation today, and thanks very much.
Is that up now, Ollie?
Yep, we're all.
All right. Thank you very much. Yes, thanks both for the introduction. Thank you all for the opportunity to present to you this afternoon. Apologies, my camera isn't working. Think I need a new laptop from Santa, but I've learned a lot from these events and the blogs that follow them over the past couple of years now. So it's a nice opportunity to contribute in some small way to the excellent network that's been set up here. So just to briefly introduce my own background, I've been an NHS consultant in sport and exercise medicine for the past 10 years with Manchester Foundation Trust. And it's really in that setting that my interest in the topic of exercise-induced leg pain arose. In the NHS, I was often witnessing referrals in with this presentation, and I felt they had kind of a long and often unsatisfactory patient journey. So I took it on myself to just try and learn a bit more about the thing. More recently then, as the guys mentioned, I've started as a consultant with the Orth Team Centre at the Spire Hospital in Manchester. And some of the local people on the webinar may know the setup. We have over 40 specialists from a range of backgrounds, including upper and lower limb orthopedics. We have 5 MSK radiologists, so excellent cover there. Sports cardiologists, pain and neurology consultants, and we're now up to 5 SEM consultants. So a real broad range of specialists who provide a very strong team for us to deal with cases that are referred in. And as you'll see from the talk, like with many presentations, exercise-induced leg pain does often require a multidisciplinary approach. And although uh, when I reflected on things, the opportunity obviously exists within the private setting to try and arrange some of the investigations a bit quicker. But I think a key take-home point of this talk today will be the importance of taking an educated history for these patients, and that effectively can be done equally in the NHS as in a private setting. So, as well as that clinical work over in England, I've also been the senior men's team doctor and chief medical officer for the Northern Ireland men's football team for the past 13 years now. So, like a lot of people, again on the call, I'm sure my practice straddles both elite sport and looking after the active general population. And I think the important to note that the clinical problem of exercise-induced leg pain can happen in either of those settings. So obviously for an athlete, it can have a significant detrimental effect to their career. But even for the patient who wants to, say, run a weekly park run but is unable to do so, this issue can be extremely frustrating in my experience. And it robs them of a lot of the benefits that we know come with regular physical activity, such as cardiorespiratory, metabolic, or even psychological well-being. So it can be a very, very important thing to try and get right for the patients. So what do we mean by exercise-induced leg pain? It's really an exertional pain in the leg that's caused by a patient's normal or desired levels of exercise. It is usually between the knee and the ankle joints, but the thigh and foot can also be affected and involved, as you'll see. Um, and so, as I prepared this talk, I was reflecting really on why I found it unsatisfactory presentation to manage for many years. And there's a couple of things really that spring to mind. And I found that a patient would often arrive at my clinic already having had a couple of fairly miserable years. They were either undiagnosed altogether or potentially diagnosed incorrectly, either by themselves or by a medical practitioner. There is, I find, quite a lot of self-diagnosis in this presentation. Individuals who are quite motivated to get better, and sometimes your task is initially to unpick that and to help the patient see that there may be other causes that have not yet been considered. In my experience, patients would be referred into my clinic if they had anterior shin pain. They would either be labelled as shin splints, which is now really a label that should be consigned to the dustbin. It's not really a diagnostic term, but unfortunately still commonly used by medical practitioners even. So either shin splints or medial tibial stress syndrome for the anterior shin pains, or chronic exertional compartment syndrome for the calf pain. And even that in itself is a little bit of an issue. As you'll see in a later slide, almost half of the patients who do have chronic exertional compartment syndrome will be affected in the anterior compartment of the shin. And it kind of goes beyond the remit of this talk, but there is the important distinction between acute compartment syndrome and chronic exertional compartment syndrome. I'm sure most of you or all of you will know that, but I think an important thing to keep in mind is that if a patient is told they have compartment syndrome, the first thing they'll go home and do is Google it. And if you Google that, most of the images now actually on Google image or a Google search are filtered out because they're quite gory fasciotomy surgeries. And that could be quite shocking for most patients if they're told they have compartment syndrome. So then what I would find is when a patient would arrive with one of these labels, they would usually have had a trial of conservative management before reaching me. That would usually be physiotherapy or a trial of orthotics. I guess if that works or had worked, they wouldn't reach my clinic. But the fact that they came to my clinic meant that would have failed. So they would typically present a couple of years after the onset of their symptoms. The severity would be increasing. They'll have tried something which hasn't worked, and they come fairly desperate for a solution. They were usually young individuals, sometimes competitive athletes, who were unable to reach their desired levels of activity. And when I reflected on my early days as a consultant in the NHS, I would tend to send these patients for two specific investigations, which would usually be lower limb MRI scan and or compartment pressure testing, both of which had long waiting times on the NHS. And then frustratingly for myself, but even more so for the patient, these would often return normal. And when I reflect back now, having a greater knowledge of the different causes of this presentation, they probably were not the most appropriate investigation for every patient and probably unnecessarily prolonged the diagnostic pathway. So can you imagine, or as you can imagine, patients would feel very frustrated and feel back to square one if they've waited for an investigation that has returned normal. So I think these are the reasons I found it in the past quite a difficult presentation to deal with. And I'm not sure if that's something, an experience that resonates with some of you on the webinar today. And so, as I said, I believe a lot of the reason for this is suboptimal pathway is poor knowledge base of the other potential causes. So as this famous quote goes, if all you own is a hammer, every problem starts looking like a nail. And I think this applies here. So you've got to ask yourself, what is in your diagnostic toolbox when you're faced with a patient who has exertional leg pain? And I look back and think that a lot of patients who were labeled with MTSS or CECS, chronic exertional compartment syndrome, and in some cases, even being offered surgical treatment for compartment syndrome, that was often without due consideration of the other potential causes of their symptoms. Because at the end of the day, you can only diagnose what you know. And as I said, if this is resonating, the good news that hopefully from my talk is that there is kind of help on the horizon. Um, I attended two seminars on this topic last year down in London from this a working group that was set up from experts on exertional leg pain, led by Professor Nat Padhiar, who's been an expert looking at this condition for 30 years now. And last year they published this scoping review, which was entitled Developing a Diagnostic Framework for Patients Presenting with Exercise-Induced Leg Pain. And in this review paper, they identify 9 distinct clinical entities which can present with EILP. Obviously, there are others, but it was this working group's opinion that most of the presentations can fit into one of these 9, which we'll go through in a moment. And what this has done is really created some momentum around the diagnostic terminology and the presentation as a whole. And they're currently working now on some consensus documents on the diagnostic terms, but then also investigation and structured management. So look out for those on the horizon. And as I was saying to Andrew and Ollie before we started there, the hope, I guess, would be that this has a similar impact that the Doha consensus paper on groin pain had around a decade ago, where people are speaking a similar language, both for diagnosis and treatment. So Professor Nat Padhiar, as I say, I've seen him speak a number of times, and he always stresses that the most important thing is the history. So what the patient actually says to you. If you know the right questions to ask them and you listen carefully, you'll be well on your way, I guess, to getting a correct diagnosis before even examination or investigation. So questions like, is it bilateral or unilateral? How soon into exercise does the pain come on? How quickly does it settle is another key thing. And what's the character of the pain? So that's just to highlight, as I say, the importance of the history and the symptoms. So moving on now, what are the clinical entities they detailed? So the first two we've mentioned, tibial stress fracture, popliteal artery entrapment syndrome, which is definitely getting increased knowledge base and awareness out there, myofascial tears, lumbar radiculopathy, superficial peroneal nerve entrapment syndrome is the most common. There's lots of other nerve entrapment syndromes. McArdle syndrome, which is a little bit of an outlier, as you'll see, and accessory or low-lying soleus. So if there's anything on that list that you don't know of, you've never heard of, it's a good opportunity, I guess, to go and have a read about them. I'll touch on them all a little bit today. Obviously, for time purposes, we can't go into too much detail, but I think the key point is if you don't know what any of those are, you won't be able to diagnose it or potentially diagnose it. And I hope to just illustrate these with a few patients that I've seen over the past year or two in my own clinics. On this slide, I've compiled a lot of the key points, both from that scoping review, but also from some other papers. On the left-hand side, you see the nine clinical entities, and then key points underneath: history, examination, and investigation. You will get these slides so you can maybe refer to this in the end. But I think the key point from this is not to jump straight to investigations, because the key point again is these findings on your history. So moving on now to cover each of these in brief. Chronic exertional compartment syndrome usually I find presents in athletic patients, endurance athletes. It's always bilateral. The pain that a patient will tell you about is very predictable in its nature. So it'll come on around the same time in a run or on a hike or whatever it might be. And the pain builds up to a crescendo to the point where the patient can no longer continue. So that's a key point. They can't push through the pain barrier with this condition. Another key point is that this pain settles very quickly after they cease the activity. So if you're getting these key points in the history, that you're well on your way to a diagnosis. The examination tends to be almost always normal at rest. And just to show here the different percentages of the different compartments, the anatomy is key to know here, that there are 4 different compartments in the lower leg, and you can see there yourself the percentages that are affected. People often just jump straight to thinking you need compartment pressure testing for these patients, and it's often called the gold standard, but it's actually only the gold standard for the acute compartment syndrome. There's a lot more controversy around its usefulness in the chronic exertional compartment syndrome. The pressure criteria is different depending on the centers that are used, and the emphasis really should be on a clear history. And you definitely shouldn't be doing or referring a patient for this investigation unless you have a very strong, high degree of clinical suspicion, because you can see yourself, it's an invasive procedure. People are getting needles put into the 4 compartments of their leg pre-activity, after activity, and sometimes now during activity as well, to see the pressure waveforms. Just to mention, before COVID, I remember a local surgeon who does these compartment pressure testing And the fasciotomies presented a case or a series of 14 patients he had done these on. Mixed outcomes on the investigation, but all 14 went on to have fasciotomies, which we'll show you in a second. And of those 14, only 8 had satisfactory symptom relief. So I would suggest that possibly some of those 14 patients, or some of the 6 that didn't improve, didn't actually have compartment syndrome in the first place. So this is the surgery that patients who are suspected of having it go on to have. A fasciotomy. It can either be a full length one or a couple of incisions with an instrument placed down in between under the fascia to separate it. This is a recent patient I was involved with who had acute compartment syndrome. He's a professional footballer, so you can see the scarring after the surgery. We had a little bit of problems finding a physio. Well, the club physio was uncertain, should I say, about rehabbing after the surgery. So I found this as a post fasciotomy rehabilitation program, which you might want to refer back to if you're ever involved with a patient who has had a fasciotomy for this condition. We'll not go through it now, just for time purposes. Moving on then to the next condition, which is commonly diagnosed, medial tibial stress syndrome. Again, it's usually bilateral, not always. The shin pain, it's anterior shin pain on the medial aspect of the tibia that unlike compartment syndrome, it doesn't immediately resolve after activity cessation. This pain can linger for hours and even days after activity. On examination, then there will be a diffuse tenderness on palpation along the posteromedial tibia, and the MRI may show paraosstitis. It's quite interesting, I think, for a condition that's commonly diagnosed. No one actually knows, well, there's no consensus, should I say, whether it's a bone stress issue or if it's periosteal traction from the muscles that attach onto that area of the shin, which are the soleus muscle, tibialis posterior, and flexor digitorum longus. But I think by and large, it gets lumped in as a kind of bone stress issue, given the name of it. So then moving on from that would be the tibial stress fractures. A key point in the history of this would be a recent load increase. So I see these in people training for their first marathon, for example, often in academy footballers who are moving up from training with under 18 players to more senior professional environment. It's also commonly seen in soldiers who have to walk for long distances. And the pain that they get is at the very outset of their exercise. So as soon as they start to exercise, the pain comes on. Unlike the medial tibial stress syndrome, it's a pinpoint tenderness, as many of you will know, most commonly at the distal third. An inability to hop is another key point on the examination. X-ray can be normal in these, so you can't rely on a normal X-ray. One tip that I heard was you have the benefit of having the patient in front of you plus the X-ray, so you can very accurately measure, say, from the medial malleolus to their point of tenderness, and then do the same on the X-ray and blow the X-ray up, and you can often see subtle changes. Whereas the radiologist who's reporting the X-ray doesn't have that benefit, so they may report it as normal. So, but nevertheless, I think MRI scan plus or minus a bone scan is definitely the investigation of choice for these patients. I get a lot of referrals in with query stress fractures of the tibia, foot, hip, and a lot of times no one's thought to check the vitamin D level. So it's something that you should think of. Try and do it early in the pathway, because if they have very low vitamin D, the bone's not going to want to heal. And although on the NHS the treatment level is deemed to be 50, for any patient with bone stress injuries, whether it be a fracture or just a bone, on the spectrum, you should be aiming for a level of around 100 or above. This is a common classification system. See, interestingly here it says for medial tibial stress syndrome, but I would use it more for stress fractures. So to go into this in further detail, my colleague John Rogers, who works here at Orth Team as well, he gave a very comprehensive talk on this on the network earlier in the summer. I think it was July. So if you go back, you can have a look at his talk and the blog, which was excellent as well. Change of tack now to the next clinical entity, which is a vascular one, popliteal artery entrapment syndrome. It wasn't something I knew about whenever I started, even as a consultant. I think maybe just around the time I remember hearing a talk on this, and 2 weeks later diagnosed my first one in a boxer who had to give up running as a result of recurrent calf pain, and then took up boxing in her 40s, but could only box maybe 5 rounds, and then she would develop calf pain that made her stop. So they get like a claudication, like exertional calf pain. It's usually unilateral, but in a third of cases it's bilateral. And what's actually happening is occlusion of the popliteal artery by a muscle. It's usually if you read the textbooks, it's usually the medial head of the gastrocnemius, but I've seen it with the popliteus muscle. And I've also read about it being caused by a high muscle belly of a plantaris muscle. So it's not always the gastrocnemius. The pain with these ones can take hours to days to subside again. It's important to try and get a early diagnosis for these, because if they keep having these episodes, it can cause long-term damage to the arterial vascular system distally. And so the key investigation is a duplex ultrasound with plantar flexion. And then if that's positive, often patients go on to have MR angiography, dynamic angiography. So you see here the image on the right, side is normal, but the left side shows occlusion of the popliteal artery. And so the vascular flow to the distal leg is affected. These images are from that first patient that I saw a couple of weeks after learning of the condition. So you can see it's not small surgery. Nowadays, thankfully, they tend to try a couple of Botox injections into the muscles to try and reduce the symptoms. So it's not straight to this. And this is just something that I find that I think illustrates what I was saying. So this is two cases of misdiagnosed popliteal artery entrapment syndrome, two young patients with persistent lower leg pains. Both had been treated with bilateral 4-compartment fasciotomies for presumed compartment syndrome with no effect on their symptoms. And then subsequently, vascular imaging showed that they had popliteal artery entrapment syndrome, and they had cures from treatment of that. So people are even having fasciotomies when they don't even have compartment syndrome. Sticking with vascular issues, this isn't one of the entities, but it's a patient who I saw, a 52-year-old male. He was an athletic patient and he had diabetes, but he presented with progressive right calf pain on exertion. And when I examined him, he had palpable distal pulses in his foot and behind his knee, but he had an absent right femoral pulse. And then on investigation with the arterial duplex, on the right hand side here, these are the common iliac arteries. And I don't know if you can see on the left common iliac artery, there's good blood flow. On the right side, there's complete occlusion. And then you have all these little accessory vessels beneath that. So he'd had that occlusion for a long time, smaller vessels had opened up beneath to allow the blood to flow. And that's why when we examined him, he had absence of a femoral pulse and presence of the more distal pulses. So it's just to point out that when you're examining these patients, you can't just check the pulses in the feet, and if they're normal or equal, assume that the vascular system is normal. So you need to know where to actually physically check for these pulses. Next condition then that can cause exercise-induced leg pain is a myofascial tear. If you go back in the history, I've seen these in a couple of rugby players, and if you go back in the history, they've taken a heavy bang to the front of their shin, potentially like 2 years earlier, something like that. And these are the trauma ones are the ones that present with unilateral, and if they present with bilateral, that can be due to a congenital weakness. They present with anterolateral shin pain and swelling with activity. What's actually happening is the engorged exercised muscle is protruding through a defect in the myofascial coverage. So importantly, the diagnosis or the investigation for this is not MRI scan, but a dynamic ultrasound, which is often positive. And I've seen quite a few of these recently on dynamic ultrasound. So you need to know this is the investigation to order. So you see here, this is an ultrasound of the anterior leg at rest, and then after exercise and in a certain position, you can see the fascial defect, and it's usually the tibia muscle that protrudes through. Patients are asked to go into a fencer's position, which is what brings the muscle through most prominently. So it's something you can ask them to do in clinic to try and bring on the bulge. And often, let me just see if often if you can, I had a patient recently, and all they wanted to do was know what they had. They were happy to modify their activity because they knew it wasn't anything to worry about. These lumps came up and the pain associated with them. These are just some surgical images. You can see the defect in the myofascial cover, and then that gets stitched up. I came across this preparing the talk, which is a suggested rehabilitation program for patients who have this. So I think it would be useful for the physiotherapists out there to have a look at this slide in particular, because not every patient will want to undergo surgery, obviously. So there are things that can be done prior to referring on to a surgeon. You can go through that in your own time. The next clinical entity is lumbar radiculopathy. Now, we'll all have seen patients in our clinic who have calf pain, thigh pain, hamstring pain due to low back, lumbar conditions such as disc bulges. But less frequently, it's an exertional thing without back pain initially. So the key points on the history are that they're more likely to have rest pain, and more likely to have nighttime pain. There may be associated paraesthesia, so pins and needles or numbness. And obviously then when you move on to your clinical examination, there can be positive clinical signs such as a positive straight leg raise test on that side or a positive slump test. And MRI imaging of the lumbar spine is really the investigation of choice. I had this interesting patient maybe 2 years ago, a 24-year-old male who kept getting left-sided calf pain when he went for a hike, which he enjoyed doing regularly. And he was referred to my clinic with chronic exertional compartment syndrome, and asking could we arrange compartment pressure testing. A key point, I guess, on the history was that he was able to walk through his pain. It wasn't like he was stuck up the mountain and couldn't walk. He got the calf pain, but he still was going on hikes. So if you remember back, a patient who did have compartment syndrome, they would have to stop immediately. And this guy, he had no back pain, but after a while, we had him under our care in the clinic for a while, and he did develop back pain. So we imaged his back pain, and you can actually, or we imaged his lumbar spine, and it's very subtle. But on this X-ray, he had a thing called Bertolotti's syndrome, which may be new to some of you, and it was new to me at the time actually. So what Bertolotti's syndrome is a combination of changes on sacralization of the lumbar vertebrae, where the transverse process fuses with the sacrum. That's actually quite common, and now that I see it on reports all the time now. But when it's combined with back pain, it's given the term Bertolotti syndrome. And key thing is that these patients can present with radicular leg pain that precedes the back pain. So obviously, and it can be unilateral or bilateral. And obviously, then you're going down a completely different uh, management pathway than some of the other previous ones. So I think this guy had injections, which helped, but sometimes patients need surgery. So that's a kind of central radicular nerve issue. Um, there are peripheral things. So superficial peroneal nerve entrapment syndrome is something you definitely should know about. Again, I've seen a few of these, maybe 4 or 5 over the past 2 years, so it's definitely out there. And patients come in complaining of exertional pain and altered sensation over the anterolateral shin and the dorsum of the foot. Tend to be endurance athletes. And what's actually happening here, if you imagine an engorged exercised muscle is pushing the superficial peroneal nerve up against the myofascial coverage as the fascia as it exits. And so key on the examination is a positive to nails. So you work up from around the lateral malleolus up the anterior shin, anterolateral shin, and you may get a positive to nails. And this notion of anatomical pain mapping, sorry, it's not come up, but I've got the wrong order. But basically, if you draw on the patient's skin the site of maximal pain and the area of pain or paraesthesia, it can be a good clue to diagnosing this condition. And further investigation then or confirmation of the diagnosis is done with a guided local anesthetic injection at the site of the nerve exiting. If a patient has that, then you can try as a halfway house an injection of steroid around that. But if that doesn't work, then patients do sometimes need surgery. So you can see on this image the superficial peroneal nerve underneath the fascia, and then that gets released with a neurolysis, and then that tends to solve the problem. McArdle syndrome is as I said at the very start, an outlier. It's a cause of exertional muscle pain and weakness. So it's a rare genetic disorder. Around 1 in 150,000 people have it. It's a type 5 glycogen storage disease, one of the more severe glycogen storage diseases. And what actually is going on is a deficiency in the enzyme PYGM, which is called muscle glycogen phosphorylase. And that enzyme is needed to break down glycogen into glucose for energy for the muscles, essentially. And so if a patient doesn't have that enzyme, they're unable to utilize their muscle glycogen stores. How this presents, it's usually a young person in their 20s, and they come with exercise intolerance due to muscle pain and weakness. They will obviously, because it's in the anaerobic stage of exercise that they'll have the symptoms. So they'll have muscle pain and weakness at the very start. Say, for example, they're running for a bus. They'll get pain in their calves. But what's pathognomonic of this condition is this second wind phenomenon. So if they're able to jog, say, slowly and move from the anaerobic stage of exercise into the aerobic stage of exercise, they can then suddenly find that they can exercise. So they might be able to jog slowly for long periods, but not that initial anaerobic stage. So hopefully that makes sense. Investigation of these people involves checking their creatinine kinase, which is usually chronically raised even at rest. And then you can go on to do other things such as a post-exercise lactate graph, which is diagnostic. And sometimes patients get genetic testing and muscle biopsy. It's difficult to access these. We're fortunate here in Manchester at Salford. They have the muscle disease unit, which you can refer patients in with suspected McArdle syndrome. But I've started just checking a creatinine kinase on a lot of these patients, expecting it to be normal, but just as a check for this condition. Finally, then, the last entity is an accessory or low-lying soleus muscle. This is present in about 3% of the population, and it presents with a soft mass in the posteromedial distal calf. It's usually unilateral, and the symptoms can mimic compartment pressure or compartment syndrome. Important to note that this is often asymptomatic. So when you investigate for this with imaging, if they have it, it doesn't necessarily mean that it's the cause of their symptoms because it is fairly common, as you say, 3%. So don't automatically think that if you see this on imaging, that's why they're getting symptoms. You can see here on the right calf a low-lying soleus muscle. It's not. It's actually a second soleus muscle. It's not the main soleus muscle, which is low-lying. So again, just back to that overview slide, which you can refer back to. Time 45 minutes, so we'll wrap up. The key take-home points for me, you've got to approach a patient who is coming with this presentation of pain whenever they exercise in the legs. You've got to have a broad differential diagnosis. A solid anatomy knowledge is obviously very helpful, as you can see from this presentation. And taking an educated history is really the cornerstone of the diagnosis. Then you go on and you arrange or you do an appropriate examination and arrange appropriate investigations. You don't just throw the same investigations at every patient. Thankfully, there's these consensus papers on the diagnosis, investigation, and structured management on the horizon. So keep an eye out for those from I think it's the London group or London Hospital in East End of London. And I think you should consider an SEM referral because, as you can see, for a lot of these conditions, a multidisciplinary approach to management will be helpful. And I think a sports medicine doctor may be the most appropriate person to kind of be at the center of all of that. So that's my talk finished. Ollie, if you want to jump in, if there's any questions, be happy to try and answer them.
Perfect. Thank you, David. Right on time as well. That was an excellent presentation. I'm sure there will be lots of questions. I'll just remind everybody watching now, if you could post your questions into the Q&A, it'll massively help us keeping them organised. We have got our first one, which is on CCS. So if that is the diagnosis, are there any compartments that work better with fasciotomy and ones that are not as effective?
Well, if I go back to the slide, I think I don't know that there's I don't know the answer to that question if I'm perfectly honest with you.
Good answer.
Yeah, I think you can see like the two most commonly affected are the anterior and deep posterior. So that's going to be 85% of the cases. So I can find that out, I guess, from one of the surgeons that I know locally who does it. We tend to refer into either Wrightington Hospital or Oswestry, who both are experienced in doing the compartment pressure testing, and then if it's positive, they'll take the patients on to do the fasciotomies. But I stumped already with question number one. Apologies.
That's all right. Maybe it's, if we do get anything back, maybe it's something we can put in the
In the blog.
post event blog. Yeah. Second one's just going in. How soon should we refer to a physician if we expect acute CS? What's the best pathway and time frame for intervention effectiveness?
Uh, into the vascular surgeons, would be the most appropriate. I've diagnosed acute compartment syndrome once, which was in Northern Ireland, very randomly in a friend of mine who I lived in Australia with, and then I was doing a locum shift in an NE, and he came in and I was like, "You've got acute compartment syndrome," and no one in Belfast would take it on. The general surgeons were trying to put it to the vascular surgeons and vice versa. But here, the one that was done recently though was done by one of the foot and ankle orthopedic consultants, Mr. Pillai, who works at Withenshaw Hospital. And that patient, it's basically an emergency. So you don't, if you suspect it at all and the patient's getting more and more pain, you get on the blower and you try and arrange it urgently and you let people know that what you're suspecting is acute compartment syndrome. Um, so that, yeah, I think it's basically a surgeon who will be prepared and experienced in doing the fasciotomy. So as I say, that could be a foot and ankle surgeon. It could be a vascular surgeon. It depends probably on your locality or what services you have locally.
Great stuff. We've got some very good questions coming in. I think this is because we're on a lunchtime session, everyone's still fresh.
Hmm.
The morning coffee's still lying about. It's a good one from Dylan on the pulses. Can you explain again how patients can have a normal dorsalis pedis pulse but an absent femoral pulse?
Yes, so let me just go back to so that yeah, this was the gentleman I had in clinic, and he had absent femoral pulse on the right hand side. He had weak popliteal pulses bilaterally, but he did have palpable foot pulses bilaterally. So when I investigated him with this arterial duplex, there was complete occlusion of the right common iliac artery, which is, I
Hmm.
don't have a pointer, but basically the
Yeah, these
left
are
of the
right.
red one's coming off. Yeah, so that's the right common iliac. So you can look, this is his actual scan. So if you see where it says right CIA
Yeah,
and left CIA, so blood flow on these ultrasound duplexes is it's either blue or red, depending on whether it's coming towards you or going away from you. So if there's color there at all, that means there's blood flowing through a vessel. So you can see there's blue coloration in that left common iliac artery. And on the right is just a black hole, really, a black mass. So that's indicating that there's absolutely no blood flowing through the right common iliac artery. So it's a chronic stenosis of some description. I think this guy ended up having all sorts of angios in his heart and things afterwards. Is lots of like vessel disease all over his body. But because it's been so chronic, all those little red dots below the right common iliac artery are what's called accessory vessels. So over time, all the small little vessels in his leg that are would just be small veins that usually carry a little bit of blood, they've all widened and they're now carrying more blood to accommodate for the blocked right common iliac artery. So as a result of that, blood is kind of getting past the blocked right common iliac artery and is now perfusing the rest of his right lower leg. So blood then gets down to the knee, gets down to the foot. Does that make sense?
yeah, I hope so. Dylan, let us know in the chat. Have we answered that? Um, let's do the next one. So with the spine syndrome, have you ever seen the peroneal nerve being compressed higher up at the lateral gastrocnemius? That's from Nina.
No, I haven't personally, but I sent a patient recently on the NHS for nerve conduction studies for this,
Hmm.
checking to see if there was changes, and it was rejected because I had been told that doing post-exertional nerve conduction studies would be helpful, and it was knocked back by the neurophysiologist who said, no, that's not a helpful investigation. So I think that's why I've put down as the diagnostic thing is a guided local anesthetic injection. So I think it would be difficult to know where what the site is going to be if it's not at the exit point where you can see the nerve coming out with an ultrasound. Maybe there are cases, I'm judging by the question, that there are cases where the nerve is being entrapped more proximally, but I think if you had a good, and that's why we benefit here at Orth Team Centre, we've got really 5 really good MSK radiologists. So if you ask them your clinical query for that, they would find the nerve at different sites of potential compression. Try a local anesthetic block at the different sites and see if the symptoms resolved. We can also here get people on a treadmill, so you can ask them to run, bring on the symptoms, do a local nerve block, and then get them to run again, and you can get a very quick answer as to whether the intervention has worked, and then you can, based on that, you can do something a bit more definitively, such as a steroid injection or potentially even like a surgery, as I showed. So no, I haven't seen anyone personally with a more proximal nerve compression.
Great stuff. We're back to the compartment syndrome now, but conservative management this time. So just a question on what conservative options there are there, and whether there's any role for soft tissue work in that.
Uh, yeah, so I think so there is definitely a role for conservative stuff. Like not every patient is going to go straight for that surgery. Um, so what a physio could get involved in, I guess, is correction of lower limb biomechanics. There's Andy Franklin Miller did a lot of work on this, like biomechanical overload syndrome, mimicking what people thought were chronic exertional compartment syndrome. I didn't feel I had time to go into a lot of that today in the talk, but it's definitely something worth looking into. So I guess, yeah, correction of the lower limb biomechanics, targeted strengthening, stretching, gait re-education for a lot of these patients can be useful. And joint mobilization and manipulation. So there's plenty that a physio can do to try and alleviate these symptoms alongside orthotics. As I say, I would often see patients maybe beyond them trying a lot of that. But it just depends where you're seeing them in the patient journey.
Yeah, bro. Um, I don't normally do case presentations, but it's an interesting one from Jennifer, and I have a feeling the answer might be I don't know, or I don't have enough information. And if it is, that's fine. But we're going to try it. So a patient who began with exercise-induced leg pain, but that's been occurring over multiple years, nearly a decade, to the point where the presentation becomes 24/7, mostly described as a tightness with the pain, and developing a sloshing type sensation during exercise and a constant tightness or squeezing. Doesn't have to stop exercising through the pain. Uh, MRI clear, duplex ultrasound clear with nothing to explain the symptoms, pressure tests inconclusive, and no relief from dry needling and physiotherapy throughout the years.
Did you ask if it's a male or female patient?
Uh, Jennifer, can you just add that to the to your question? I can see you've already said thank you for discussing it. So I'm just trying to keep an eye on the chat. Female, ex-military.
Female. Yeah, there was one thing that I was gonna include. It's not on that paper, but I saw a patient in clinic who I think had endometrioma of like an extra pelvic endometrioma. So basically endometriosis that had gone traveled outside the pelvis, and it does have a bit of a predilection sometimes to go into a nerve a nerve sheath. So whether it's the femoral nerve sheath, um, or the sciatic nerve sheath, and in those when I read about it, those patients initially, like endometrioma pain, it can be cyclical, so they get it along with their menstrual cycle.
Hmm.
Then what happens is they get these deposits of endometriomas in the nerve sheath that are just end up irritating the nerves constantly. So it goes from being cyclical initially to just constant pain, which can be
Yeah.
associated with exercise. So that would be maybe one thing to look out for, to see, get like a pelvic scan, and potentially an MRN, which is an MR neurography, to check the large nerve sheaths to see if there's any possibility that there's extra pelvic endometriomas.
What again, pathway locality dependent, etc. But what would the referral pathway normally be for that person out of what I'm assuming is private practice physiotherapy by the looks of it? So what
Yeah,
if that person's going back in
it,
through the sort of GP front door,
yeah.
what are you asking for?
Well, endometriosis on its own is, I think, an average time of diagnosis is 7 years. It's the diagnostic pathway is a nightmare. It just,
Mhm.
despite all the education efforts. So I think for something like that, I would refer to gynae. Um, and just it's hard to say that. I don't want to say that because I don't know all the details.
Yeah, yeah,
But
of course.
uh, gynae or a sports medicine physician
Yeah.
here at Orth Team or elsewhere would maybe be a good
Because
starting point.
I suppose the first thing you're thinking is we're now starting to think that it's something non-musculoskeletal, so we need someone who can consider all of the non-musculoskeletal things that it might be.
Yeah, yeah. And I think, again, probably a sports medicine doctor's best placed to take that overview.
Yeah. Okay, brilliant. Um, that is the end of our questions and pretty much spot on the end of the session as well. So Andrew, if I can bring you back in as well at this point, just to wrap us up.
Thanks, Ollie. Thanks very much, David. Brilliant presentation. Great to see lots of people online. I think we'll be trying a few more lunchtime slots, so I'm glad that's what today. David, it was brilliant, fascinating to see all the sort of different syndromes and conditions that people should be thinking about, and it's sort of really good to have some signposts in terms of these are the things where they can sort of upskill their knowledge and go away and look into a bit further. So. Great to see lots of good questions too. So thanks very much. Have a good Christmas, everyone, and we'll see you in the new year.
Thanks very much.
Thanks, everyone.
Bye.